Hi everyone, my name is Tom Doyle. I'm the Chief Executive of Yorkshire MESMAC, and I wanted to speak to you today a little about how we've reintroduced community-based HIV face-to-face testing here in Yorkshire, England. So a little bit about Yorkshire MESMAC. We're a public health charity established in 1990, and we work with most at-risk populations. Our main focus is on sexual health and mental health, and the key groups that we work with are LGBTQ plus populations, Black and minority ethnic groups, as well as other most at-risk populations. We cover a large area in the north of England with bases in Leeds, Bradford, Wakefield, Rotherham, York, North Yorkshire. We cover a population of around 3.2 million people. And for those of you who don't know Yorkshire, it's a very diverse county. It has some of the fastest and richest cities in the country, as well as it's part of the most deeply rural part of the country with declining coastal towns, as well as very affluent parts of the country. So we have a very diverse population group. In terms of our HIV and STI testing offer, there are two main strands to this offer. The first strand is testing times. This is a service that's delivered by community workers, so not medically trained workers, non-medics, and that service is made up, we can test for HIV, syphilis, chlamydia and gonorrhea. The HIV and syphilis tests are point of care tests or near patient tests. Chlamydia and gonorrhea are swab tests that are then sent off to labs with a text result to the service user. The second element of the service is Testing Times Plus, which is delivered in conjunction with a nurse from our clinical partners from the NHS, from the National Health Service, and that offers the same service as Testing Times, but with the addition of wider STI screening using bloods, vaccinations for hepatitis A and B, and HPV. We also offer cervical screening for women, both cis and trans women, cis and trans men, and we offer contraception advice. So why did we introduce face-to-face testing, first of all, particularly in light of COVID-19? Well, the first thing to say about that is it wasn't a standalone decision. It was part of a wider overall strategy as part of our bounce back strategy following the outbreak of the pandemic and relaxation of lockdown measures here in England. And this list basically outlines the priority and order in which we decided that we would reintroduce services as and when local restrictions allowed. And the first one was testing in our building, and the second one was PSE outreach delivered outside. PSE is our public sex environments, so they're areas where people would meet to have sex, usually anonymously, so parks and lovers' lanes, those sorts of things. Then we thought we would be able to reintroduce one-to-one services in our buildings and outdoors, delivered by our staff. So that would be things like one-to-one support sessions and information giving. And group meetings outside, obviously respecting local restrictions. Though they're coloured in different colours simply because That's as far as we got during the first phase of lockdown and relaxation of lockdown measures before new lockdown measures were reintroduced. So why did we prioritize community testing over other areas of our work? Well, first of all, there was a demonstrable need. A lot of our services, in fact, the majority of our services, moved very quickly online and over the telephone, and we were getting lots of requests from our service users around wanting a HIV test and an STI test. And it's very clear from our work, both online and talking to service users over the telephone, that there was risk taken before lockdown, but also during lockdown. And indeed, our outreach, our virtual outreach on hookup sites such as Grindr and Bareback RT and so on, it was very clear to us that there was a lot of sexual activity still happening outside of people's bubbles and outside of people's homes. And on top of this, we also saw a reduced capacity within clinics, our NHS clinics, because they were responding to COVID-19 and introducing new measures, but also a large number of staff were redeployed to COVID-19 duties. So there was a general lack of capacity. There was also quite an interesting narrative happening at this sort of time in England. There was a real feeling from some parts and some commentators that lockdown presented us with a real opportunity to break the chain in terms of HIV transmission. And given what I've said before, we thought that this narrative was over optimistic, that we were really clear that people were still meeting to have sex, and what we were fearful of was that STIs would go undetected and untreated and treated late, and that once lockdown measures were relaxed, that we would see a huge spike in STIs. And we really didn't want that to happen. We wanted to keep on top of that as much as we possibly can. So first of all, we saw the need, and the second question was, can we do it? Were we able to mitigate the risks of C19 to our service users and to staff? And there was a roadmap for us to do that. We have lots of learning from our clinical partners, how they'd responded to COVID-19. Clinical sexual health services run by the NHS didn't close ever during C19, so we were able to learn a lot about how they were able to mitigate risks. We were also very clear that we had control over our setting, that we're operating from our own buildings, and an additional benefit and additional arm that we had in our arsenal was that we had a bespoke online booking service which we could control, and we could control the messages that were going out through the booking services. We could control the time and the time between appointments and all of those sorts of things. So our environment was very controllable by us. We also had control over the procedures that we decided to do and how we did them. And I guess the really big advantage for us was that staff really wanted to do it. Staff were very clear that there was an ongoing risk, and you know, I think it's a great testament to their commitment that they wanted to do this. And kind of the third thinking around why community testing was, whilst there were alternatives to face-to-face testing in terms of postal kits in particular, these were suboptimal for lots of people, and also some parts of the areas that we worked in hadn't signed up to the National Postal Testing Service by this time, and so were unable to access it. And the only way they could access a postal testing kit, particularly at the beginning of the epidemic, would be to pay for it, and that didn't work for lots of folk. So where we are now, so the current state of play, we reintroduced face-to-face testing the week of the 15th to the 5th to the 16th of July, so quite soon after the restrictions were lifted slightly. And some of the key changes and mitigations, we, like most other services, do a pre-test screening for COVID-19 contact and symptoms. We're able from that to refer people into the National Track and Trace system or to their local testing services. We only have booked appointments, so we no longer offer walk-ins or drop-in services, which used to account for a large number of our testing throughput. We're able again to offer the booked appointments because we have an online booking system, which I'll talk a little bit more about later on. One of the ways that we managed to reduce not only the number of contacts, but also the time of contact is to take this sexual health history over the phone prior to attendance. So folk are spending less and less time face to face. So again, cutting down on chances of transmission. We introduced quite a number of procedural changes in terms of how we do the test. Some really simple ones in terms of where people sit, what angle they sit when facing the service user in front of them, but more fundamental ones, and the largest one I think their service user would probably notice is that they now would take their own pharyngeal swabs, whereas before a worker would do that. And obviously in terms of mitigations, we have PPE staff for service users, we have PPE for staff and for us, our service users. Service users are unable to bring a mask, we'll supply them with one, and all our buildings have been risk assessed and are COVID secure with one-way systems and sanitisation stations and all of those sorts of great things. So we'll talk a little bit. I'm going to skip through this next section, but people please do look at the slides at your own leisure in terms of the pre-test discussion and triage. This is basically a flowchart around our discussion with folk in terms of assessing risk and to COVID-19 and contact to potential COVID-19 in terms of symptoms and contacts. And these are the questions that we would go through in the process that we go through during the telephone triage and pre-test discussions in terms of taking people's sexual health history. So in terms of booking a test, as I said, service users can only book a test via our online testing portal, though they can ring the office, and if they don't have access to the internet, and a worker will book the test for them using the portal. Our testing system, you can find that at www.bookatest.mesmac.co.uk. Please do have a look at that. And as I've said, what it's really fantastic at is that it allows us to manage who comes into our building and when. We're able to really reduce the risk of service users crossing paths by we've extended the appointments now to 1 hour, which allows us to wipe down and, as I say, reduce the risk of service users coming into contact with one another. We've found that this is it's more than enough time for us to do everything that we need to do, and we are looking at maybe how we can change that time and perhaps reduce it a little. What's not on this slide is during the pre-test discussion, we asked the service user when they arrive at the building to call a mobile phone number, and then the worker will go down to the door to meet them and escort them through the building as well. As I say, we're always about having the fewest people in the building as possible, and so our staff have been split up into pods. This is also about if a case of COVID does occur, that the whole staff team isn't put at risk, and we could at least carry on with a minimal service. I guess one of the issues around this too is that a lot of our staff really did want to come into the building and come into work, as much for anything but for that social interaction that work gives folk. I mean, I think we all know that work is about more than work. It's also a way of us connecting with other people who we like and want to be around. So this allowed us to do some of that whilst ensuring that staff were kept as safe as possible. So just some reflections and learning from our experience of reintroducing face-to-face HIV and STI testing. A key, and the key, I think, is that staff are taken with us, that we win hearts and minds when we want to reintroduce testing. We were very lucky that we were able, because of the size and diversity of our team, that there was no expectation on the staff to test. Because we were doing the telephone triage as well, staff who were perhaps nervous or vulnerable or shielding, we were able to redeploy those into non-contact duties. So some staff who were particularly vulnerable but did want to be involved, they were able to do the telephone triage, for example. I think if we are reintroducing the service, we need to recognise that COVID-19 impacts on our staff as well as on the service users, and so we need to be practicality around people's lives and flexible around people's lives and their practicalities. So, you know, we have to recognise that people have childcare arrangements and so on, and what do we do about getting staff into the workplace, particularly in terms of things like public transport, and can we take make reasonable changes to protect staff as much as possible. Our staff were involved, and staff at every level were involved in developing our risk assessments, and also led on redesign of procedures. Now, while staff, frontline staff in particular, aren't necessarily health and safety experts or experts around risk assessments, they are experts in how the mechanics of how a testing session works. And it was really important that they were involved in looking at ways of mitigating any risks during that, and I think their insight and expertise were instrumental in allowing us to be able to open up the service. And also that, you know, it's very clear that staff feel an ownership of those risk assessments, and so then far more likely to adhere to them if they've been involved in their design and their development. And also, you know, just general good practice about regular catch-ups and reflection on practice and any tweaks that we might need to make in terms of the procedures and risk assessments. In terms of some of the barriers that we faced, some of the very practical ones, and particularly early on, were when everyone was trying to support source supplies around PPE and buildage, signage, etc. That took a lot of time, and you know, we were also very mindful that we didn't want to prevent PPE going to NHS services. So, you know, it did take quite a lot of time for us to get a reliable supply of PPE. Our clinical partners from the NHS offered us supplies in the early stages, but could only offer us small amounts because obviously they didn't know what the demands for their services were going to be. And so it's important that we had an independent supply, for us. Understandably, detailed advice from our public health commissioners were not available. They were rushed off their feet. They were obviously facing an unprecedented epidemic like everyone else, and their priorities, I think, were in other areas, and so, you know, they just didn't have the bandwidth to be able to do the detailed work that we needed to do. And I guess one of the pieces of advice I would give other services in our situation would be to do that detailed work, to go to your commissioners or public health people with a plan, with a detailed plan, which they're able to sign off, rather than expect them to be able to do that piece of work for you. Another barrier which we've thought a lot about is that the reliance on digital is problematic, that it does underserve some key population groups. You know, we didn't want to cement health inequalities that have been highlighted by COVID-19. We didn't want to have those embedded into the service going forward, and we've done a lot of thinking about how we can do that. And, you know, the very simple thing around allowing people to call us so that a member of staff can make that appointment for them online seems to be working. But even so, we know and we've observed that without our outreach boots on the ground and face-to-face outreach to most at-risk populations in real life, that fewer people from those groups as a proportion of the service users are using the service. And I think it's really important that we do whatever we can to not only stop that happening, but to reverse that. And particularly early on in the epidemic, there was a lot of narrative around we're all in this together, which was great and felt really, really useful. But there was also a more judgmental narrative around some of the responses that we got online, in particular when we were talking about, if you're still hooking up, our services are still open, you can come and get a test. And we got some pushback from some members of the community, you know, saying why these people are hooking up, or they're being stupid, they're COVIDiots, all of those sorts of things. So I think we need to be clear about how we message our services, and also clear about how we talk about COVID-19 and make sure that the messages we're sending about COVID actually don't get in the way of us producing and delivering effective HIV prevention and testing services. So going forward, and sustainability, it's the 11th of November today. England entered our second national lockdown on the 5th of November. We've done an assessment of where we're at. At present, we think all the measures are sufficient to continue delivering the service, and we intend to continue delivering the service. Longer term, and something that we do have to think about, is that we're seeing reduced numbers, and that does increase the unit cost of each test that we do, though the do not attend rates have decreased, so that's sort of balanced it out a little bit, but it's undeniable that every test that we're doing is costing more during COVID-19 than it did beforehand. That being said, we're still paying staff their salaries, and there's some activities that they're not doing, and so they're spending more time on testing. So the overall numbers haven't decreased massively. And I guess in terms of service development, one of the things that we've been most surprised about is the acceptability of pre-test telephone discussion being really acceptable to the majority of service users. And that's probably something that we will carry on after COVID-19 to offer to service users. I think that's particularly important for perhaps those folk who are wanting to access a very quick HIV test, perhaps during their lunch break at work or whatever. And we could perhaps, and we're looking at perhaps offering a more express service once our services return to pre-COVID-19 environments. And the final message I guess I'd like to leave you all with is that face-to-face community-based HIV and STI screening and testing can be done safely and effectively. Thank you.